Welcome to this Pearl of Laboratory Medicine brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls as well as other free educational material at traineecouncil.org.
Hello, my name is Kazunori Murata. I'm an associate attending clinical chemist at the Memorial Sloan Kettering Cancer Center. Welcome to this Pearl of Laboratory Medicine on diagnostic criteria for multiple myeloma. I would like to begin by talking briefly about what exactly multiple myeloma is. Multiple myeloma is a hematologic cancer that develops in the bone marrow. It is a cancer of plasma cells, which are cells responsible for making antibodies in our bodies. On the slide is a picture showing plasma cells in bone marrow against a background of myeloid and erythroid lineages. Multiple myeloma belongs to a group of diseases known collectively as monoclonal gammopathies. The common characteristic among these diseases is that they occur as a result of an abnormal neoplastic expansion of a single clone of plasma cells. This is opposed to the normal distribution of plasma cells in a healthy human, which is a polyclonal distribution. This means there are millions of individual clones with the number of cells from each clone making up only a tiny, insignificant portion of the total number of plasma cells in the body. Monoclonal gammopathies, on the other hand, are the result of one clone of plasma cells taking up a disproportionate fraction of the number of plasma cells in the body. There are many different kinds of monoclonal gammopathies, and such disorders include monoclonal gammopathy of undetermined significance, also known as MGUS, smoldering multiple myeloma, Waldenstrom's macroglobulinemia, solitary plasmacytoma, light chain or AL amyloidosis, Poems syndrome, and of course, multiple myeloma. Multiple myeloma is a relatively rare disease. Its incidence is estimated at approximately 4 to 5 cases per 100,000. It consists of only 1% of all cancers, although it comprises 10% of all hematologic malignancies in the U.S. It is also a disease more prevalent among the elderly, with a median age at diagnosis of 66. Risk factors for the disease include advanced age, Black race, male gender, and family history of myeloma or other monoclonal gammopathies, all contributing toward an increased risk of developing multiple myeloma. The pathophysiology of multiple myeloma can be quite complex. However, it is typically associated with 4 major dysfunctions, typically referred to as CRAB, an acronym for calcium, renal, anemia, and bone. Myeloma patients often get hypercalcemic due to lytic bone lesions caused by plasma cell tumors outgrowing their confined space in the bone marrow and invading the bone. This breakdown of bone increases calcium in the blood and can lead to other neurological symptoms. The renal symptoms in myeloma are typically caused by tubular damage caused by monoclonal free light chains secreted by the plasma cell tumor. In the more advanced stages of the disease, free light chains can deposit in and obstruct the tubules in the kidney, causing significant renal damage. The anemia is typically due to the crowding out of cells for red blood cell production by plasma cells in the bone marrow. It can also be due to the reduction in erythropoietin caused by severe kidney damage. Finally, bone fractures, often in the axial skeleton, are caused by the expansion of plasma cells in the bone marrow. Understanding the natural course of multiple myeloma is key to realizing the important role that laboratory tests play in the management of patients with multiple myeloma. Typically, multiple myeloma is fatal without treatment, and as of present, myeloma is an incurable disease. That being said, there are now highly effective treatments available, with more options being developed as we speak. Many of these treatments have been shown to significantly prolong survival while simultaneously improving the quality of life. Unfortunately, all patients will ultimately relapse after treatment, requiring a change in therapy to one which the myeloma will respond to. This necessitates regular periodic monitoring of the disease in order to detect relapse. Laboratory testing plays a key role in monitoring response to treatments, as well as detecting relapse in treated patients. The diagnosis and monitoring of multiple myeloma can be accomplished by multiple means, but typically include a thorough clinical examination and history taking, imaging, including conventional X-rays, CT, MRI, and PET scans, and pathology, which includes examination of a bone marrow aspirate and/or biopsy. Laboratory tests also play a key role in the diagnosis and monitoring of myeloma. Hematologic and other basic clinical chemistry tests, such as calcium and creatinine, are often ordered in conjunction with more specialized tests, such as serum and urine protein electrophoresis and immunofixation, as well as serum-free light chains when a diagnosis of multiple myeloma is suspected. The diagnostic criteria for multiple myeloma is currently determined by the International Myeloma Working Group, or the IMWG. The IMWG is an offshoot of the International Myeloma Foundation and is an international consortium of more than 200 leading myeloma researchers. This group has developed guidelines for the diagnosis and management of multiple myeloma. It is important to keep in mind that these criteria are constantly evolving and updated every few years to reflect our increasing knowledge of the disease. The most recent diagnostic criteria for multiple myeloma were issued by the IMWG in 2014. The current diagnostic criteria for multiple myeloma that was issued in 2014 places great emphasis on the tissue damage caused by the myeloma as well as biomarkers. These criteria were based on our current understanding of myeloma disease progression and were updated to allow for treatment of patients who are at high risk of progression to symptomatic disease and would benefit from therapy. Furthermore, these criteria may also allow myeloma patients to potentially live longer if they were treated before serious organ damage occurred. In order for a patient to be diagnosed with multiple myeloma, a patient must have clonal plasma cells in the bone marrow greater than or equal to 10%, or a biopsy-proven bony or soft tissue plasmacytoma with clonality established by flow cytometry, immunohistochemistry, or immunofluorescence. In addition to this, a patient must meet at least one of the following: either the presence of related organ or tissue impairment, i.e. CRAB criteria, or the presence of a biomarker associated with near inevitable progression to end organ damage. In this slide, I would like to elaborate a little more on the second criteria. The presence of related organ or tissue impairment, also known as the CRAB criteria, refers to the pathophysiology of myeloma that I went over a few slides back. As I mentioned before, myeloma patients typically suffer from one or more of the four major dysfunctions: hypercalcemia, renal insufficiency, anemia, and bone lesions. Under the IMWG guidelines, each of these impairments have objective definitions. Anemia is defined as hemoglobin less than 10 grams per deciliter or 2 grams below the reference range. Hypercalcemia is defined as serum calcium greater than 11 milligrams per deciliter. Renal insufficiency is defined as estimated glomerular filtration rate less than 40 milliliters per minute, or serum creatinine greater than 2 milligrams per deciliter, and for bone lesions, one or more osteolytic lesions on skeletal radiography, MRI, CT, or PET-CT. One of the new additions to the 2014 IMWG diagnostic criteria was the addition of MDEs, or Myeloma Defining Events, to the definition of multiple myeloma. A patient displaying any one of three criteria, in addition to greater than 10% clonal plasma cells in the bone marrow or biopsy-proven plasmacytoma, is considered to have multiple myeloma. These three criteria are: 1. Greater than or equal to 60% clonal plasma cells in bone marrow. 2. Involved, uninvolved free light chain ratio of 100 or more, with a minimum concentration of the involved free light chain being greater than 100 milligrams per liter. And 3. MRI with more than one focal lesion involving bone or bone marrow. These myeloma-defining events have been shown through studies to be associated with near inevitable, i.e. 80% or greater risk, progression to end organ damage, and are thus considered defining biomarkers for multiple myeloma. This new addition to the criteria is important as it allows for physicians to begin treatment on patients at an earlier time point before end organ damage has occurred. I mentioned in the beginning that multiple myeloma is just one of a group of diseases called the monoclonal gammopathies. It should be noted that each of the other monoclonal gammopathies also have specific diagnostic criteria. In the interest of time, however, diagnostic criteria for these and other monoclonal gammopathies will not be reviewed here. However, those interested can review them on the IMWG website. I would like to end this session by mentioning that the IMWG also has guidelines called the Uniform Response Criteria for multiple myeloma. The purpose of these response criteria is to facilitate precise comparisons of efficacy between new treatment strategies for multiple myeloma in clinical trials. The classifications include complete response, very good partial response, stable disease, progressive disease, and relapse. A key thing to note with many of these classifications is that laboratory tests such as serum protein electrophoresis, immunofixation, and free light chains are highly influential in determining what category a patient will be classified under. Laboratorians should be aware of this, since these classifications often affect clinical care decisions made for patients enrolled in clinical trial protocols. Thank you for joining me on this Pearl of Laboratory Medicine on diagnostic criteria for multiple myeloma.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.